I'm going to go through the formal presentation really quickly and then talk about really what RADV is. And we will hear a lot more about that tomorrow from Tom Hutchinson. Basically, the RADV subgroup of the RADAR ICE team was, our mission statement is to facilitate the collaborative development of efficient tools and processes for health plans and providers in conjunction with a CMS RADV audit. Our deliverables, standardized request forms, a contact list of key individuals and/or departments from medical groups, health plans, and providers. And just in case any of us have forgotten, what simplify means is to make something less complicated or easier to understand. So we all have to share best practices with risk adjustment. And we've come to the conclusion we all have to share best practices with RADV, with documentation. How do you train physicians? How do you incentivize them? And the reason is those findings are extrapolated across a population. One of the questions that came up for the Ask the Experts section was, how is it going to be extrapolated from a plan down to the providers? I mean, you have groups. Sue's group is a great example. They're doing everything right. They're proactive. They're doing random reviews. They're coaching their physicians. But if they belong to a health plan who gets hit, what's the effect going to be on them? All their work, and if this is extrapolated across a population, who knows what the outcome will be. We went through the stages of data validation audit, and the sampling and the medical record request is that information that comes from CMS and says, here's what I want to see. The medical record review itself is the plans and providers who have to gather that data. There's a there's a medical record finding and a contract level payment adjustment, i.e. the extrapolation. There's a documentation dispute that goes back and forth, post-documentation dispute, and an appeals process. What we did is we came up as a group with a sample of a medical record request timeline, and all this information is posted on the ICE website, in the hopes that everyone who participates in a RADV audit, and that's all of us in this industry, could adhere somewhat to this guideline because it's very tight. At the outmost, plans have 12 weeks to get that information back to CMS, which means they have to look through all their information when they get their list from CMS, and they have to decide who are they going to ask for the records, send out the request, get the request back, and go through every single one of those medical records to find the one best, and then send it back into CMS within a 12-week period. On a standardized request form, we had narrowed it down to stating the reasons you need the information, i.e. an audit, identify the collection period under review. This would be the data service. Note if a vendor is involved. Did it go from the provider of service, whoever that may be, through a vendor on to the plan? Are there any HIPAA concerns about giving the medical records to the requester? And also include the CMS instructions with the specific member information that is under review. Now, from where I sit, this was the most important thing that we came up with, because the medical records, we're in a 2007 data service audit. It's 2 years old. By the time the request goes out, it'll be 3 years old. It's really important to know where to go to get those records. It's important for IPAs, medical groups, hospitals, health plans. Who is your contact? And what we learned, and what we all agreed on in one of the ICE rules and regulations, we can't post that kind of information, i.e. personal or work contact information, without the direct consent of that person. So we're setting up a link on the ICE website. If you are that person at your plan, or at your IPA, or at the provider site, or at the hospital, if you are that person, please go to that site and put your name in there. Put your name, your contact information, your position. It's sort of a heading. It'll be similar to this, so that anybody within the ICE organization that does get audited in a RADV audit, and they get the members identified and they know who they belong to at the time, they know where to go, because that's half the battle. So, questions? Yes, Pam.
So one of the things I think would be helpful for this work group, I really applaud getting the contact information. Mm-hmm. We've been doing RADV for quite some time, and one of the things I think would be also helpful is helpful hints for the folks that are going to be pulling from the provider groups this information together. So basically, health plans get this information through encounter data because we're a capitated market here in California. Most generally, you'll be able to pinpoint the primary care physicians. You're not going to be able to pinpoint which specialty physician provided that service on a claim, because a lot of times the health plan systems don't capture down to the specialty. It'll just be lumped in under the group or whatever. So it's really important for the groups to understand that when you get this, you need to go into your claim system at the groups, look at where all of the claims for this member so that you're pulling every medical record from every single physician that this member saw. Because it's not all, we're so into primary care physicians, and we always think primary care physicians, but a lot of this isn't coming from the primary care docs. So it's really important, I think, to develop kind of a training thing for the providers on knowing where to go to make sure they're getting everything, that you're looking in your claims shop to do that. Because what happens is the time frame is so short,
12 weeks max,
that once you send it and it doesn't validate, you're still back scrambling trying to find another medical record that does. So on the front end, request them all, submit them all, let someone else make the decision which one is the one best record. But it's really in the chart chases is where the key to making this happen is.
I agree. Thanks very much. And I also think one other thing to think about is, if you have that diagnosis triggering that HCC from a hospital record, go for the hospital record first. Always. First and foremost, go for the hospital record. The documentation is generally much more complete.
Yeah.
Thanks, Pam.
Yeah.
Hi, Lyle Hill from HealthSpring. Quick question. We've found some value in doing some targeted reviews in addition to the random. Can you speak to any kind of targeting mechanisms you use to do any targeting reviews if you do those?
Healthcare Partners hasn't, the question was, in addition to random, they found value looking at targeted audits. And Healthcare Partners hasn't done many targeted audits at this point. We do a lot of different things. The only targeted audits that we have done are for our specialists who are uniquely capturing a lot of HCC codes that nobody else in the system is capturing. But I know several plans have been doing targeted audits. For example, Scan Health Plan did one on acute conditions that are acute that are not expected to occur outside of a hospital setting. And the results of those were that there were a lot of retracted codes for our medical group. So definitely that's one worth doing.
Absolutely.
Looking at your pharmacy data and your PBMs, because a lot of people are not capturing diagnosis. However, we have members that are on all these meds, and you're not finding correspondent diagnosis to go along with the medications that the patients are taking. So looking at your pharmacy data and your PBMs will help to make sure that your system, your claim system or encounter data is capturing the appropriate diagnosis.
You know, one other thing I want to mention, Donovan went to the RADV training that CMS put on in Baltimore in October, and a couple things I found fascinating that came out of there, which is completely contrary to what we heard at the ICE annual from CMS last year. And first of all, their preliminary reporting, which was based on 5 MA plans, said they had these little stars next to some of the findings, and of course coding discrepancy was the highest frequency. But one of these little tidbits of new information was that if the credential is missing, a plan can use the attestation process. They use the CMS-generated attestation, and it could be substituted up front with the medical record to correct the signature and provider credentials. But an attestation won't be accepted after the submission of the medical record. So if you see a credential that you can't read the writing, or the credential isn't there, and Donna, if you have questions about it, I mean, that's information that came out at the Baltimore training.
Yeah, that's the back-end dispute process will be focused solely on issues related to whether or not you feel that CMS has made a mistake in calculating the number.
Thank you very much. Thank you very much, everyone.